Hey guys, we are going to discuss a very important topic of ECG for your Neetpg. You know you primarily get only 1 minute of time for solving a question of ECG. So the main funda, the concept is to learn the ECG in this way only so that you get this in 1 minute. You don't have that much time in exam and also at this moment so that you read ECG 2-3 hours and get every concept. So this video will focus over this only and hope it will help you in getting the ECG in 1 minute. So here we go. Thank you. Guys, I was also thinking why everyone is so scared of this ECG. Actually, what has happened is everyone has made this ECG so complicated. They are going into so detail of ECG to explain you every bit of it. But in my opinion, every bit of ECG is not needed at present. You are not a MD medicine guy at present. You have to clear this exam to become one. So for clearing this exam, the main motive will be to have this much only, which I am going to tell you. So this is the most important slide in my whole video, because you need to see every interval how much it is, and once you know this you can calculate the intervals. So one small box of ECG is 0.04 second, and one large box which consists of 5 small box will make it to 0.20 second. So one large box is 0.20 second, one small box is 0.04 second. Millivolt, one large box is 0.5 millivolt. Now one small square in a similar way is equivalent to 1 millimeter, and one large thus becomes 5 millimeter. The calibration of a normal ECG is 25 millimeter per second. This figure is to tell you different intervals which are there and what are their normal values. So please note it down. If you have a register, PR interval starts from P up till R and it is less than 3 to 5 small square. In a similar way, the other QRS complex, ST segment, QT interval, all are important for you. Now the similar type of diagram, some normal values like heart rate, normally we consider it at 60 to 100 beats per minute. PR interval between 0.2 to 0.20, QRS less than 0.12. SA node and AV node. SA node similarly, AV node discharges at little lesser rate of 40 to 60 minute. Ventricular tissue discharges 20 to 40 minutes. Now at this time only I'll tell you that graph also from this, because here some normal values are given. So you see the P wave, the normal height of P wave is 2.5 millimeter. Okay, that means 2.5 small box, and the width is 0.12 second. Now if the width is more, that is P wave is wide, we consider it as left atrial enlargement and P mitral. If the P wave is tall, okay, so if P wave is tall, that is greater than 2.5 millimeter or 2.5 small square, it is called P pulmonale or right atrial enlargement. PR interval is normal 0.12 to 2.20 second. First degree heart block, it increases because there is delay in conduction. WBW, it decreases to less than 0.12. QT interval normal is 0.36 to 0.44 second. These values are important, guys. So when you see QT prolongation in hypokalemia like this, and hypocalcemia and class 1A drugs, arrhythmic drugs, when you see QT short end, that is less than 0.6 when there is hypercalcemia, and in case of 1B drugs, QRS less than, normally it is less than 0.11 second, but in RBB it is greater than 0.11 second. Osborne wave seen in hypothermia, delta wave in WBW, and these are some of the MI and characteristic of MI. And hockey stick sign reverse in case of digoxin. Hyperkalemia and hypokalemia we will discuss. I will also post this picture in my comment section. From there you can just see it and go through it and note it whatever is needed for you. Now the best way to see the ECG is to see starting from rate, rhythm, cardiac axis, and then every wave and interval, so as to identify what is the diagnosis. Now once you get the diagnosis, right away go towards the answer. You need not to go further step. This steps may seems very long, but once you get the answer, you need not to go further. So the simple how to calculate heart rate you all know. Between RR you will count the large square and divide it between the by the 1500. Okay, and this will get you the answer. In this case it is 1500 divided by 3 large boxes, it comes to 100 beats per minute. Now what if the rhythm is irregular? This was when the rhythm was regular. If it is irregular, you need to count the boxes, square boxes, in 6 seconds. Now by 6 seconds, what you mean? Now 6 seconds you can calculate it by two means. One is, in a standard ECG strip there is marking for every 3 seconds. Now 2-3 seconds if you combine will make it to 6 seconds, and if you count the number of QRS complexes in this 6 seconds and multiply it with 10, will give you the heartbeat. So they are not going to give you the regular one. If they give, they will give you the irregular one only. The second thing is ki I have already told you in this graph, in this picture, that one that 5 large squares is equals to 1 second. That means in 6 seconds there will be 30 large squares. So you need to count 30 large square and then see how many QRS are there in 30 large square to get the heart rate for the irregular rate of or rhythm. Now we are coming to rhythm. Rhythm is something very important. You need to look at lead 2 particularly for getting the rhythm, whether it is regular or irregular. This ECG is showing you a normal sinus rhythm. Why sinus? Because every P is followed by QRS and every QRS is preceded by P, and there is normal duration of PR interval, that is 3 to 5 small squares. Okay, and the lead is upright in 1 and 2. This is something detail of normal sinus rhythm. Sinus bradycardia when the rate is less than 60, otherwise everything is normal. Sinus tachycardia, that's why we are using the term sinus, because everything is normal except the rate. Tachycardia means above 100. And now something called arrhythmia, any abnormality in rate arrhythmia. Now if you see it is less than 60, it can be due to heart block or simple bradycardia. If it is greater than 100, it can be any narrow complex like fibrillation, flutter, supraventricular tachycardia, sinus tachycardia, or ventricular tachycardia or ventricular fibrillation. Now you must know how to identify each of them, but we'll first start with the heart block. You need to see which type of heart block it is if they give you the ECG. Now it is very easy to identify. I'll tell you how. There is one poem also, but I'll tell you little later. So you see there are three degree of heart blocks. Okay, the first degree happens when the PR interval increases greater than 200 millisecond. That is one large square. So it has increased and there is no other abnormality. Everything is just like normal, but the PR interval has increased in case of first degree heart block. In second degree there are two types, Mobis 1 and Mobis 2. Mobis 1 is called Wenke batch. Now Wenke batch, what happens is, here the PR interval is increasing progressively. How? You can see in this diagram that here it is this much, now it has increased to little more and longer, and then you see a drop. That is no QRS wave. So in Wenke batch you see PR interval longer, and then a drop. So this is Wenke batch. In Mobis 2, however, PR interval is greater than 200 millisecond, but it is not progressively means increasing, it is just constant, something greater, and then you see suddenly a drop. So it is not related with progressive increase of PR interval. Okay, so it is Mobis type 2. And in third degree there is constant PP interval, and constant QQ interval, and they means the drop can occur anywhere, there is no any such correlation. So this is something detailed of them. In first degree again you see कि just PR is prolonged, everything is normal. In second degree Wenke batch, PR interval becoming progressively longer until one P wave is blocked and now a drop. In second degree Mobis type 2, what happens is there the PR interval has increased, but there is some drop after some ratio, like uh, two waves are normal, then a drop, like three waves are normal, then a drop, like they have some ratio like 2:1, 3:1 type of block. Okay, in third degree, the PR interval will be like it will be elongate longer, but you see p waves are not related to the QRS complex. They may occur anywhere. The drop may occur anywhere. So this was the poem I was telling. If the R is far from P, then you have first degree, longer, 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 and drop is Venke. If some P don't get through, then you have Mobis 2. If P and Q don't agree, means break up, then you have third degree. Okay, so this was about all about heart block. Now something about arrhythmia. Sinus tachycardia above 100. Atrial tachycardia is series of 3 or more consecutive 3 atrial premature beats occurring at a frequency greater than 100. Atrial flutter and fibrillation, you need to differentiate between flutter and fibrillation. I'll show you with the ECG strips. Just know that the sinus rate of flutter is 250 to 350 beats per minute, and fibrillation, it is just uncoordinated atrial depolarization. In a similar way, regarding ventricular arrhythmia, flutter is greater than 200 per minute and fibrillation is just uncoordinated ventricular defibrillation, depolarization. Now this one is atrial flutter. In flutter you particularly means see sawtooth pattern. So you see the pattern is just like sawtooth. And how you consider it as atrial? For differentiating between atrial and ventricular, you first need to see which one is normal and which one is abnormal. So you see in this diagram, in this ECG, QRS complexes are normal. QRS are created due to ventricular, and ventricular part is normal. Only the atria part is something abnormal. So this is something due to atrial. Now you need to differentiate between atrial fibrillation and flutter. So in flutter you will see sawtooth appearance, and in fibrillation no P waves can be seen. Okay, so the fibrillation is uncoordinated atrial activity having no P wave, and it will be irregularly irregular. But in flutter it is somewhat of organized electrical activity with the rate of 250 to 300 and sawtooth pattern. Remember it, sawtooth pattern. You see in fibrillation you cannot see this sawtooth pattern. These are T waves actually, not the P waves. Okay, so in flutter you again I am saying you see sawtooth pattern, and this is something fibrillation, because here you cannot see the beautiful QRS waves. Can you see it? No. So these are ventricular fibrillation and ventricular tachycardia. In fibrillation it is completely disorganized, no associated waves, no discernible P, QRS or T waves, and in tachycardia just the QRS is greater than 120, that is wide complex, and rate is greater than 100. So I think you got a very important concept. This is just again to show you the atrial fibrillation and atrial flutter, the sawtooth pattern, the ventricular fibrillation and ventricular tachycardia. Okay, so you need to see them again and again to get an idea. This one is very peculiar. They may ask you and you will just get the answer just after looking at it. So this is torsid. The point is a distinctive form of polymorphic ventricular tachycardia characterized by gradual change in amplitude. Now something called supraventricular tachycardia. It is why it is called supraventricular. The name itself is telling that it is arising from above the ventricle, something from above the ventricle, supraventricular. Okay, so here also QR is normal, whatever is occurring is with the supraventricular part. Okay, and paroxysmal we will tell when there is sudden rate change of greater than 150 beats per minute. The QRS may look different after the rate of change, heart rate change. Okay, this one they may give you the artificial pacemaker, because you should know something different. They are also keen in asking something different. So this is something called the ECG for atrial pacemaker. So you can see sharp thin spikes for atrial pacemaker, and the rate here depends on the pacemaker. P wave may be absent or present, and the ventricular paced rhythm shows wild ventricular pacement. So these are the wide spaces pacemaker spikes, and the P waves are not visible as the this pacemaker is doing that part. Another, now after rate and rhythm, the important thing which comes is axis. In axis, many people are very worried, but it is very simple. You just see, I'll tell you something. You need to see ECG at lead 1 and AVF. Okay, so this we are considering normal axis. Between minus 30 to plus 110, we are considered at normal. Now what you need to see ki whether the wave QRS is positive or negative in 1 and AVF. How you will know कि it is positive or negative? If the R is greater than S, it will be positive. Means R minus S, something is coming positive. If here, as you see, S is longer than R, so it will be negative, and here it is equiphasic. Another thing which you need to see is this one is positive for lead 1, and this one is positive for AVF. This one is positive, negative for AVF, and this one is positive for lead 1. Now with example I'll tell you, you will get this, I'm sure, because see here in lead 1, if you see, it is positive, R is bigger than S. So for positive, you see, it will be like here for lead 1. Okay, lead 1 positive. AVF, if you see, it is again positive, so AVF was positive below. Now if you draw it, it comes like this. Okay, so the vector, the common vector will be somewhere here, that is between 0 to 90 degree, and it will be just normal axis. Okay, so when you will see left axis deviation and when you will see right axis, when they are just like this, means when you get a curve in this part, it will be left axis. When you get a curve in this part, it will be right axis, and here it will be extreme axis. I'll show you with every situation. So lead 1 positive, lead AVF positive, so it is normal axis as already discussed. Lead 1 positive, lead AVF is negative, that is upside, so vector going this side, that is left axis deviation possibly. Lead 1 is negative, lead AVF is positive, that is here, that is right axis deviation, and both negative is the extreme axis. Now axis is also over. This is something easy for you, like if you see both are in lead 1 and AVF, both are going opposite, that is it will be left axis deviation. Left leaves and right returns, so both are going towards each other, so this is right returns and left leaves. So just a simple mnemonic. The causes I'll post in my community section. From there you can see it for LAD and RAD. This is something important called Wolff-Parkinson-White syndrome. What you have to see here is the delta wave. So delta wave is a characteristic wave seen here above the blue bar, and you can also see shorter PR interval of 0.08 second. Okay, so this is for Wolff-Parkinson-White syndrome, where there is accessory pathway called bundle of Kent, which allows early activation of ventricles. Now moving to the each wave or complex separately, QRS complex is important, and it should be less than 3 small squares. Why I am saying this? Because you need to see LBB and RBB. This is also very important. You need to just remember William has left bundle branch block, or William is left-handed person. So it means you need to see two, V1 and V6. V1 is coming first, V6 then. So William means William. Okay, so V1, W for V1 and M in V6 for LBB, and opposite will be for RBB. In the figure also you can see this is W in V1 and M in V6. So this makes you LBB and RBB concept. ST segment is important for deciding whether it is MI and whether it is ST elevation or non-ST elevation. Another thing which you need to remember here is what is the site of location of MI. You need to see in which leads are showing changes. Like if you see in inferior MI, you will see changes in lead 2, 3 and AVF. And how you will remember, sometimes you may confuse whether it was AVF or AVL or AVR. Always remember inferior has F in it and AVF has F in it. So 2, 3 AVF for inferior wall MI. Note it down guys, it is important. So when it is significant, ST elevation should be there in two chest lead and greater than 2 millimeter elevation. So then it is called the ST elevation significant MI. Now these are the sequence, not that much important. And even then I'll give you in the community section. Now tell me this part, which MI is this? So here you can see the ST elevation in two leads, and this is for means this V1, V2, V3 and all. So this is for anterolateral MI. I'll show you one peculiar inferior MI where you get in lead AVF, lead 2 and lead 3. So this is particularly means particular for inferior MI. Now there is something called non-ST elevation MI. In that, how you will identify it? So excuse me. So here you can see either a ST depression or a T wave inversion with or without ST depression. Okay, so this is also a MI, but here you don't see a ST elevation. It is also known as subendocardial or non-Q wave MI. Okay, so it is very important. So how you will diagnose it? Confirm the anstomy. If positive, do the troponin test. If positive, it is diagnosed as non-ST elevated MI. If negative, it is unstable angina pectoris. Okay, so here you can see some T wave inversions and non-ST elevated MI. So one thing as a MCQ, ST depression is more suggestive of myocardial ischemia than infarction. So this is very important. Pericarditis also shows ST elevation, but what you observe is there is a concavity before ST elevation. So here you can see there is in every lead there is some concavity before the ST means with the along with the ST elevation. So this is not for MI but for pericarditis. So this also forms important. Digoxin, you all know there is a reverse tick with digoxin. Okay, so this is particular for digoxin, you should all know. Now ST segment, why it is important for identifying LVH and RVH. In LVH you will see one criteria called SV1 and R in V5 or V6 should be combinedly greater than 35 millimeter. So if you get this, it will be a LVH. So here you can measure it, as you already know what are the dimension of small squares and large square. That's why I was saying the first slide is very important. Every criteria depends on it. And RVH, there will be right axis deviation. V1 R will be greater than S, and V6 S will be greater than R, and there may be a T wave inversion. These are the some common causes. I'll post in the community section. QT interval. Now QT interval is also important. You need to see whether QT, what is happening in hypokalemia and different condition with this QT interval. So this is QT interval. Okay, this whole part is the QT interval. It should be less than two large squares, that is 0.35 to 0.45 second. Okay, so this one was the QT interval, and it is prolonged in some condition like congenital long QT syndrome. Okay, but it can also be due to some medication. You need to know every medicine. I'll post in community section again. Antiarrhythmic, TCA, phenothiazine, it forms an important question for your MCQ. Electrolyte imbalance and ischemia. Okay, so long QT syndrome is an inborn heart condition in which repolarization of heart is delayed. T wave is equally important, and what you see here is in hypokalemia you see prominent U waves. So these are the prominent U waves, which are normal U waves are small, round, symmetrical and positive in lead 2. Okay, so it is in same direction as that of T, and these are thought to be representing feature of repolarization of papillary muscle or Purkinje fibers. So U waves are important. Now two important condition: hypokalemia. You see this beautiful narrow and tall peaked T wave as an early sign. Then what happens is PR interval becomes longer and P wave loses its amplitude and may even disappear. QRS wave widens. Okay, what happens in hypokalemia? T wave become flattened and there becomes presence of a prominent U wave. The ST segment may become depressed or T wave inverted. Hypercalcemia and hypocalcemia, usually signs are not obvious, but what I was saying, QT interval is important regarding this. So short QT interval will be with the hypercalcemia, so opposite happens, and with hypo you will see long QT interval. Okay, so I think I have discussed most part of the ECG, and it will help you surely. So, and I'll post that a smaller section in the community, most of the important things in community section. From there you can get it. Till then, stay happy, stay blessed, stay focused. This is Dr. Shivam signing off. Thank you.